Okay, good morning, everyone, and thank you once again for joining us for our Northern California and Southern California PGA Town Hall chats. Our thanks to Tom Annis and the Southern California team for this great partnership. And on behalf of our boards of directors and staff, we thank you for the support and feedback we have been receiving for these chats, because that helps us to guide us in the next topics and the speakers to bring on. And we have some very, very valuable information today. As we have said, and it is important, please continue to utilize the resources on ncpgalinks.com, scpga.com, and also pga.org, as those links keep us in real time on so many issues, from small business administration loans to pga.org, pga.coach, the use of our online library now, which is available through June 30th. At no charge, and even the rosters for the counties here in Northern California to keep up to date with what's happening in your backyard. You know, we are encouraged by the announcement of the PGA dates, August 6th through 9th here at Harding Park, the US Open in September, our local events such as the Safeway Open and the Barracuda and the Masters moving to November, because that keeps us forward looking. That keeps us looking to that period when we roll back again and involve ourselves in the greatest game of all, and the game that we've dedicated our professions to. So certainly it's a long road between now and then to get to those events, but we're grateful that the conversation has turned that way and gives us a chance to do some planning and look to the other side. We've got some tremendous speakers today. We have Dr. Bella Matias, who is the Chief Health Officer and Deputy Director of Health and Social Services for Solano County. Mike Bryant of Dudum Financial to discuss health insurance implications as relating to COVID-19. And also Steve Tellis with the company of AFRCT to discuss some of the unemployment issues relative to independent contractors, sole proprietors, and ourselves as well. And of course, Craig Kessler. Craig keeps us on the straight and narrow and is our voice to what's happening at the California legislature. So I'd like to turn this over to our Northern California section president, Dee Dee Moriarty.
Okay, thank you, Len. Hey, there's lots to talk about. So just really briefly, thanks everybody for the opportunity just to reach out and say hello from San Francisco, and really grateful for the technology that allows us to stay all connected. We're about 35 or 36 days in the house trying to be part of the solution, and it definitely is an unusual experience. And just sending best wishes. You know, for many, this is a holiday week that hopefully will give us some hope and optimism for our future. And I think that's really, really important. And was just thinking this morning, if I take about a 3-minute walk from my house, and I can look over at Lake Merced and really get a close view of how beautiful Harding Park looks today. So my wish is sincerely hoping that the PGA happens in whatever form. I know people are really looking forward to seeing some live golf and the joy that would bring to people. So stay safe, everybody. Best wishes to your family, and thanks again.
Thanks, Dee Dee, and welcome everyone. This is another webinar in a series, as Len said, and we're really happy to be with you this morning and welcome around 200 of you, at least right now, from really all around the country, and that's very nice. So thanks for being here. One thing we need to discuss, or at least point out, is the question link on this webinar. Please ask your questions. Caitlin and Bryce and other members of the PGA staffs will put the questions in line and try to get them answered. If they're not answered today on the webinar, we will respond via email from whatever staff person is available for a response, whether it be your section staff or PGA of America staff. So please understand if the questions aren't responded to and answered in today's webcast, then you will have an answer. So please ask your questions. Those are quite important. Along with the other websites, I'd like to remind you that the other organizations' websites are full of information as well. And if you have a chance and want more emails and more newsletters, sign up for the newsletters that are out there. It's all good information. I know sometimes we get overwhelmed by emails, but at the same time, during these times, it's really important to stay in tune with information, especially in your local areas and your local agencies and the information that they provide to you. So with that, back to Len and look forward to our panelists this morning.
Thank you, Dee Dee. Thank you, Tom. And Dr. Bella T. Matias is currently the Health Officer and Deputy Director of Health and Social Services for Solano County here in California. He's previously served as Chief of the Communicable Disease Emergency Response Branch of the California Department of Public Health, and briefly serving as Chief of the Disease Investigations Section. He's also served for 13 years as Medical Director of the Epidemiology Program in the Massachusetts Department of Public Health, after serving for 4 years as the Medical Director of Disease Control and State Epidemiologist for the Rhode Island Department of Health. Dr. Matias received his medical degree from the University of California, San Diego School of Medicine, and completed a residency in occupational medicine, preventative medicine at the Harvard School of Public Health, where he also received a Master of Science degree in epidemiology and a Master of Public Health degree. So Dr. Matias, we can't thank you enough for being with us. No doubt your time is so precious. So we're grateful and look forward to hearing from you.
Thank you very much, Len. So let me start with some background on what it is we're talking about. The novel coronavirus called COVID-19, as I think many of you probably know, its source was human exposure, either directly or indirectly, to bats. This particular coronavirus has as its reservoir bats. And the outbreak, according to consensus, began because of human exposure to animals in a live animal market in Wuhan, China. It rapidly spread from there across the globe, and is in terms of the nature of the virus, it is now a human coronavirus, of which there are many that infect us. This particular coronavirus is very similar to SARS, and some of you may remember that we had a pandemic with SARS in 2003. And this particular one is not as virulent as SARS, but is very similar in many respects. It is a respiratory disease, and so its primary means of spreading from one person to another is through respiratory droplets. And you can clearly envision what that means if somebody is coughing or sneezing. It's obvious that we expel droplets when we do that. But droplets also spread indirectly through surfaces, through our hands, etc. And one of the features of this disease that has become increasingly clear is that the very vast majority of infected people are actually asymptomatic, or if they're showing symptoms, they're so mild that the individuals are not aware that they have illness. And in those situations, by definition, they're not coughing and sneezing, but they're still spreading their droplets through their hands, through being really close to somebody and maybe spitting when they talk, through surfaces, etc. And the mode of spread has revealed itself to be very, very similar to influenza. And we all know that influenza is highly contagious and moves around every season very rapidly, infecting a high percentage of the population. And it is a very similar model of disease spread that this COVID-19 virus seems to be demonstrating. There has been a report out that the virus can survive on surfaces for prolonged periods of time, and that it can also be found to be in the air. I would take those pieces of information with a grain of salt. The fact that under laboratory conditions it can be recovered from the air or from a surface does not relate to the ability of the virus to transmit through air or through surfaces, because the virus needs to be in a moist condition in order for transfer to occur, and there has to be a high enough dose of exposure for disease to occur in a person. And at this point, there are no data showing infectiousness through the air, and there are no data showing infectiousness through surfaces once the saliva has dried out. Having said that, these are things we have to be mindful of because it is possible. The other helpful information in that regard is that if we look at the patterns of spread in the countries that have had this disease, it definitely reflects droplet-borne spread and definitely does not reflect airborne spread. So I think the consensus is that it is not an airborne disease, but that doesn't mean that there aren't going to be some situations where spread can occur from person to person through the air. So in response to it being a droplet-borne disease, across our nation and most of the other nations in the world that are battling this virus, we have utilized aggressive social distancing in an effort to minimize or to reduce that spread. And social distancing is very often equated with being 6 feet apart, and that's too simplistic. Social distancing is actually more nuanced than that, and what it has to do with is those behaviors that we can undertake to minimize the risk of exposure to a droplet. So when a person coughs or sneezes, for the most part, those droplets will come out of the air due to gravity within 6 feet of the person's mouth. And so the rule of thumb is that if you're at least 6 feet apart from one another, then even if the person is coughing or sneezing, you're not going to be exposed. But for people that are asymptomatic who aren't coughing or sneezing, you don't need to be 6 feet apart in order to be completely protected from them. Other elements of social distancing that are very important are frequent hand washing or use of hand sanitizers in order to keep our hands clean, making sure you stay home when you're sick, coughing into your sleeve or into a tissue if you do cough or sneeze so that you don't expel to other people. And very importantly, not bringing your hand to your face without making sure it's clean. And sort of an adjunct to address the possibility of surface-based transmission is surface cleaning. And, we've all been talking about these things. We've been talking about staying physically apart from one another. We've been talking about frequent hand washing. We've been talking about stay home when you're sick. We've been talking about keep your surfaces that are frequently touched clean. And these have the benefit of reducing the transmission of droplets from one person to another. More recently, there's been talk about the use of face coverings, so not face masks, but just something to cover your face. The idea there is that if you inadvertently cough or sneeze, or if you're a person who spits when you talk, that cloth will hold it closer to your face and minimize the risk of it transmitting to other people. And so when we talk about social distancing, we're talking about a series of actions we should be taking to reduce the likelihood of transmitting from one person to another the virus through the droplets. So this disease, in all likelihood, this disease was introduced into the U.S. way earlier than we realized. There are good reports out of China that the disease was circulating in October and November, so well before they announced it in December. And as you recall, we didn't start doing any restrictions until January on travel. And if you also recognize that most of the people are asymptomatic, then what we were doing wasn't stopping spread at all, because we were really only holding people in quarantine if they had a fever. And since the vast majority don't show a fever, even during the period of time when we were restricting travel from Wuhan, the vast majority of people with sickness were still coming into our country. And so we have had this illness circulating in the U.S. for quite a long time, and it has been slowly building up. And the speed with which it builds up is affected by a number of things. It's affected by the density of the population. So if people are closer to one another, there's more droplet spread, there's more opportunity for the disease to spread quickly. If people are further apart, the spread is inherently slower. And this is not any different than what we see with influenza and other respiratory diseases. Diseases spread much more slowly in rural areas, and then in suburban areas and urban areas, they spread progressively more quickly. So across the U.S., we have seen different types of epidemic curves for this coronavirus. As you all have heard, New York City has had an explosive rise that has taxed the healthcare system significantly. In these past couple of days, they are reporting a meaningful reduction in hospitalization, And so there should follow from that a reduction in deaths within we hope, a week at most. And so they have had a very rapid rise in illness, a saturation of the population, and we anticipate that the rate of disease there will begin to drop and that the numbers of people will start to fall off. So it looks as though New York may have experienced its peak. A similar rapid rise is being observed in New Orleans and in a number of other cities. And where these are occurring, they tend to be in dense urban areas and in areas that did not do aggressive social distancing before the disease was able to start to take hold. Now, the theory behind social distancing on a large scale is not that you're going to reduce the total number of illnesses, but rather you're going to reduce the speed with which those illnesses evolve. So your peak will be flatter and not so large. And what you're doing by doing that is protecting the healthcare system from being so overwhelmed that it can't function effectively. The goal, therefore, with community social distancing is to protect our hospital system from being overwhelmed. And that's important because when hospitals become overwhelmed, people die. You can't give proper care to everyone if the hospital is overwhelmed. And so we get better outcomes and fewer deaths if we can flatten the curve. And that's why aggressive social distancing has been implemented throughout most of the country, although not everywhere. To be fair, the impact of that social distancing will not be the same everywhere. Here in California and in Washington, we have examples of relatively good benefit from that social distancing in the sense that our disease upswing has been much more gradual. And we are not observing the kinds of overwhelmed situations in hospitals that have been observed in some of the other environments within our country. New York City also tried to implement social distancing relatively quickly. It's just harder for it to have as much benefit in a city that is as dense as New York. And so the effect, the value of social distancing will vary based on these other factors as well. So here in California, we have had relatively slow growth in the disease over the last couple of weeks. Our healthcare systems are not at present overwhelmed. And there's talk about what do you do next? When is it appropriate to consider relaxing on social distancing so that people can return to their activities of daily living? And the answer is nobody really knows. All of this is unprecedented. All of this is operating on best guess in terms of what to do. The thing to keep in mind, as I mentioned earlier, is that this disease in its first wave is not going away until it has infected enough people so that there is community-wide herd immunity that can blunt further transmission. And that herd immunity is the equivalent of a certain percentage of the population having to be infected in order to protect the rest of the population. So what that magic number is will vary depending on the nature of your community. In a dense urban environment like New York City, you need a higher percentage in order to blunt transmission than you need in a rural area. So nobody really knows. Influenza, for example, every year tends to infect about 30% of Americans, but a higher percentage in cities, a lower percentage in suburbs and rural areas. For this particular disease, the guess is that somewhere between 15 and 25% of the population needs to be infected for the first wave in that area to be able to abate. So the downside of the social distancing success is that it takes longer to achieve that, and the disease sticks around for longer. And if you have people properly isolating themselves, they remain vulnerable. So then when you release them back into the community, you have a lot of vulnerables that are now available for the virus to infect, and the disease doesn't go away, it continues to infect people. But the hope is that the numbers are low enough not to overwhelm the hospitals. The other hope with social distancing at a community level is that you delay the bad peak long enough that there is treatment so that when people are coming into the hospital, they have a much better chance of surviving their illness. So all of this, like I say, at this point is educated guesswork. There is no perfect formula, and we're going to experience this coronavirus disease in our country at different rates in different parts of the country. The only good news for New York City is that they'll be able to emerge from their first wave more quickly. The bad news is that many, many people have died who might not have died had the hospital system not been so overwhelmed. The other reality is that this disease is in all likelihood going to return for a second wave, and it'll probably do that during cold and flu season. And so we're not going to get a large break between the first wave and the second wave. And in places like California and Washington, where we're still doing social distancing pretty aggressively, it's possible that the first and second waves will actually overlap. And so these are all things that we can talk about, but we're not going to know truth on any of it until we've actually observed it. I think that's pretty much all that I have in the way of remarks. Thanks.
Okay, Dr. Mattias, thank you. Thank you for that information and helping us understand more about how we got here, where we are, and where we're headed. I do see one question. It says, Dr. Mattias, do you anticipate antibody testing as part of a return to work scenario here in Northern California?
Well, I do anticipate antibody testing to become available with increasing availability over the next, I would say, 1 to 2 months. There are increasing numbers of antibody tests being approved by the FDA, but they still have to be manufactured in large enough numbers to be useful. It is unclear what purpose they will serve. I do believe that they may be used in certain industries, for example, first responders and healthcare workers, to identify people who have immunity so that they can operate more safely in a high-risk environment. I don't know how they will be used in other industries for return to work. I think that it's really inappropriate to wait for someone to be exposed and sick and recovered before you allow them to return to work, because again, if the virus only needs to impact 20% or 25% of a population, the other 75% will never develop the antibodies, and then they can't return to work for completely artificial reasons. So I don't think that the philosophy behind that makes any sense at all. I wouldn't use antibody positivity as a marker to return. I would use it as a marker to suggest that you can work more safely with a high-risk population.
Right, thank you. So, Dr. Mattias, when you talk about the second wave being pretty much on the heels of the first wave, we've probably all read and heard that the virus doesn't do well in heat. So would we expect some wane perhaps in the summer here in California, particularly in areas such as the Central Valley where it heats up pretty good, where on the coast it might stay cool? Will that have any effect on us here in such a large area?
You know, I think the effect of heat on the virus is a little bit misleading. Yes, the virus is sensitive to heat, but most of us live most of our time indoors. And indoors, we live within a certain temperature range, and it doesn't exceed that temperature range because we either air condition or we heat if it gets too hot or too cold. So the viral survival in humans, we have body temperature, and that doesn't change. So really, the virus doesn't go away because it's hot outside. Now, where it might make a difference is its survival on outdoor surfaces. So to the extent that surfaces in the outdoor environment play a role in transmission, that will reduce because the virus will be harmed by UV radiation as well as by heat. More importantly, these types of diseases diminish in the summer, not because it's hot outside, but because when it's hot outside, we have less interpersonal interactions that transmit droplets. So it's really our behavior that changes with the warm weather that causes the reduction in transmission, not the virus's ability inherently to survive. And what's interesting about that is that if we maintain social distancing through the summer, we will get no benefit from that whatsoever because we're prohibiting people from doing the very things that would reduce that transmission. So that's going to be an interesting quandary for people to have to address if we're still doing social distancing in the summer.
Okay, Dr. Mattias, thank you. So you touched on it briefly, and certainly there's no straight answer, but what are the markers that you in the medical profession and such will look at as we start to say, okay, we can get outside now, we can start to do more? So what are those markers that get us back to the grand reopening, if you will?
Well, certainly the most important things are to monitor the risk of negative impact on the healthcare system. So we're tracking availability of ICU beds, availability of ventilators. We're tracking the numbers of COVID positives who are hospitalized. These are all indicators of the worst end of the disease spectrum. And if our numbers are not going up, if they're remaining flat or they're beginning to diminish, as is the case, for example, in New York City, then that's a good indicator to be able to relax the social distancing guidelines. But you have to take that with a grain of salt, because again, as soon as you release it, more people who are susceptible come into potential contact with the virus, and you can see another peak occur. So there's no perfect science here, but there's the realization that we're doing this to protect the healthcare system and minimize death. So if we're actively achieving that goal, then we can go ahead and release the restrictions. In a perfect world, if we had way more testing available, we would also use just the total numbers of cases. And tracking total cases is usually how we make that decision, because if you had adequate testing, you could see the peak. And once you're beyond the peak, you can say, okay, we're on the downslope. Now we can go ahead and relax these restrictions. The problem is all the testing results that we are seeing are artificially affected by availability of testing, and they don't reflect reality. So we have to use the proxy, which is hospitalization.
Dr. Mays, thank you. We're encouraged certainly by your comment about the relatively slow growth here in California, and certainly good to hear that it might be peaking in New York and getting onto the other side. How can we, again, in reading and listening about shortage of PPE supplies and such, how can we best as a society, as an association, assist our medical professionals during this time?
Well, the most important thing we can do here while we're waiting for manufacturing capacity to increase is to not misuse PPE that is intended for the healthcare sector. I walk around and drive around, and I see so many people using surgical face masks when they should just be using a bandana or another type of cotton face covering. So in essence, those people are stealing precious resources from healthcare. And I think what we need to do is reinforce the inappropriateness of that. There's nothing wrong with covering your mouth, but you definitely don't need a surgical mask to do it, whereas healthcare definitely does need the surgical mask to protect its workforce. Now, hopefully in the next couple of weeks, the manufacturing efforts to produce more of these PPE will be we'll be having fruit, and we will be actually beyond the risk of shortages. And at that point, all of this really becomes moot, because there'll be plenty of supply available. But over the next couple of weeks at least, while we're waiting for that manufacturing capacity to catch up to the need, we need to be mindful as residents in our communities not to inappropriately use PPE that should be used by healthcare.
Thank you, Dr. Manis. Thank you again for all that tremendous information and for your guidance and leadership through this. Let's see, I think there might be any other questions. Okay, so one other, does Dr. see golf as a way to slowly expose people back into safer social interaction?
I'm sorry, what was the question?
So, Dr. Madison, in opinion-wise, in your view, is golf a way to slowly expose people back into safer social interaction?
Yeah, I think once we're no longer doing social distancing, leisure activities and athletic activities represent healthy ways of having people interact in controllable circumstances. Because you can well envision, for example, playing golf in a way where you maintain a pretty decent social distancing paradigm and are nonetheless being able to pursue that activity. I think the problem with regulations and emergency orders is the need for simplicity in implementing them, which then creates problems with reality, which is far more nuanced. So entire sectors have been deemed non-essential, whereas elements within a sector could be performed and still maintain complete safety for the people involved in it. Been a lot of arguments made that you can be pursuing golf and maintain social distancing. So why is it a prohibited activity? Well, it's because it falls under the generic category of leisure, which is non-essential, which is therefore prohibited. And so I think one of the problems we have to recognize when we do something on a large scale like this is the sort of the combat between simplicity and reality. And I think that's why you see different counties with different interpretations. And it's not just golf, it's also things like going to the spa or hairdressers or tattooing or recreational marijuana. You're going to see very different impressions across the counties about whether those should be prohibited or whether they should be considered essential. And I think it just sort of reveals the difficulty in having a consistent rule set across an entire state when there is so much cultural variability across the state. But in any event, I do see that an activity like golf is definitely a good step back toward normal activity that still permits us to be safer.
Thank you, Dr. Mattias. And we hope that you're able to stay with us. I understand how busy you are. So we're very appreciative of you taking your time to talk to our state of California today. And hopefully you can stay with us for the remainder of the session. Again, if you have other questions for Dr. Mattias, please put them on the question box and we'll get to them. If we can't get to them today, we will certainly forward them and stay in touch with everyone. Next, I'd like to introduce Mike Bryant. Mike Bryant is Managing Director of Dudum Financial, the largest provider of employee benefits for the private club industry in the state of California, and with a unique expert perspective on all aspects of employee benefits and healthcare reform in the private club world. And certainly, I've known Mike for quite a while and really appreciate his guidance over the years. And Mike, we'd love to hear from you in terms of healthcare relative to COVID-19.
Well, thank you, Len, and thank you everyone for joining us this morning. I appreciate the opportunity to give you a quick update on the state of health insurance and the COVID-19 pandemic. As you might imagine, I've worked in this industry now going on 20 years, and to say that what we've experienced here in the last few months is unprecedented would be an understatement. It has tested all of the resources that we have available to us, all of the business partnerships that we value so much, and it has put to the test our ability to answer questions that we had never really anticipated answering before. In speaking of health insurance itself, such a vital part of making sure that our economy and our society get through this pandemic, and what we have seen has been very encouraging on a number of levels as far as coming together. And when I say that, we've seen insurance carriers that are normally just so competitive. It is a tough business. It's somewhat of a cutthroat business at times, but we have seen the coming together of the industry to make sure that we're doing everything we can to provide the coverage to those individuals out there that truly do need it. So I'll walk you through a short timeline because we are still in the very early stages of all of this, but so much has developed over the last couple months. I'm going to rewind back to early March, where we really started to get an idea that we were in front of a tidal wave and that we needed to start to react to it proactively. And it's been a little bit of a tug of war to get to the point of what I spoke about earlier, where we have this coming together of the different players. But as you might imagine, here in California, it was driven quite early by the governor and by the government here. California instructed in very early March for insurance companies to eliminate costs when it came to COVID testing. And so carriers fell in line quite quickly with that. However, as anyone that's watched the news has seen, we can all talk about making tests free for individuals, but actually getting the tests to the people that need them has been a little bit more difficult to come by. So we're still in the stage where we're requiring pre-screening to determine if a test is needed. We've heard a lot of stories from folks about how, they can't get tested even though they feel like they have all of the symptoms of COVID. Most recently, we've had some encouragement by the CDC launching an online tool to self-screen yourself. So you can use that to see if you think that a test is needed. So we sat there in early March with that particular point. Insurance carriers listened to California and eliminated costs for testing. However, what they were sure to point out at that point was that all other treatments of COVID-19 would fall under your normal statement of benefits, which means copays, deductibles, costs associated with hospitalization would all fall under your insurance plan. Well, just in the last week or so, we've had a complete reversal of that. Health carriers have now almost universally expanded full coverage to include no cost for treatment for COVID. So we had some carriers that were very early to this point, but now we have everybody on board, and we've got pretty much everyone saying that through May at the earliest, May 31st, anyone that is diagnosed with COVID and is being treated for COVID can do so under their insurance policy at no cost. And so that's a very large give from the insurance carriers. It's been something that has been very positively received, obviously. But what we're seeing is the actual carriers are restricting individuals from coming in and seeing healthcare professionals. So we've transitioned now to individuals using telehealth, online visits to see their doctors, and that obviously falls under the umbrella of social distancing here in California. And then we've got a point where California has also directed carriers to submit emergency plans for prescription drug supplies. One of the things that we've had a little bit of not a panic but a worry over was that decreased drug supply from China due to how COVID has affected their industries there could essentially run individuals with other medical conditions into a corner and not have them have the prescription drugs that they need. So California has asked carriers to submit emergency plans should that happen, and also allow for 90-day mail orders and waivers of refills to get your prescriptions. Although most carriers were already doing something very similar, but California did make it a mandate for those carriers to do that. We've also had another mandate from California where they've actually directed the carriers to increase the availability of telehealth options. Again, as I mentioned earlier, carriers were already doing this for the most part, but we really need to get the word out to folks that they don't need to go into a physical location, that they should be using these telehealth options and online visits. And then shifting into what the employer's responsibilities are in all of this, we've seen a complete relaxation of a lot of rules that have been in place for decades. And what I'm speaking to there is, typically speaking, when an employee or an individual that has health insurance made available to them, they can enroll during an open enrollment period. Once they forego that enrollment and they waive coverage, essentially, they don't have the ability to just go back onto a plan anytime they want to. They have to have what's called a special circumstance or a special enrollment. Well, carriers have completely relaxed that now. Anyone that part of a health insurance plan that had previously waived the ability to enroll into a health insurance plan can, until April 15th, enroll. Even if they previously waived, they can also add dependents to their coverage if they have coverage in California through April 15th. So what we're doing is we're expanding the availability of health insurance and coverage to those who might need it under this special enrollment period. What that also did was it also included waiving usual waiting periods. So if you've newly hired somebody or somebody's become newly eligible for an insurance policy, they don't have to satisfy any type of previous waiting period. They can go right on to the coverage, start getting the care that they need immediately. The other thing that we've seen a lot of is a lot of questions from employers of less than 500 when it comes to the Family First Coronavirus Response Act. And that has to do with the fact that, there's no secret, we've got a complete shutdown of our industry essentially right now. We have a lot of individuals and employees that have been laid off or furloughed. And the question comes about, what do those folks do for their coverage? Well, carriers have relaxed the ability for furloughed and laid off employees to stay on insurance, and that goes hand in hand with employers being able to take a tax credit against payroll taxes for those individuals. When that first came about through that FFCRA, that Families First Coronavirus Response Act, there was some question as to how expansive that tax credit might be. Would it include, we knew it would include medical insurance. We weren't sure whether it would include dental, vision, life insurance, disability insurance, because it was a little bit ambiguous in the way that it talked about benefits under group health plans. They didn't signify particular lines of coverage. What we've come to learn through different legal opinions is that it does generally encompass dental, vision, life insurance, and all of the other types of insurance that are available through an employee benefits program. So that's within the scope of the definition of a group health plan, which means that it expands the ability for employers to receive larger credits as far as their tax credits go. So that was helpful as well. What we've really seen now is employer education has, on our part, how we're working with employers across California. Obviously, our office has gone to full-time work from home status. As many of you, might imagine, that puts a little bit of a halt on how we work efficiently with folks. We're all learning on the fly. One of the things that in disseminating information, which has become vital, are meetings such as this, what we're doing today, getting a large group of folks online via phone chats, via web chats, using Zoom to convey information, to share information, and to make sure that we're staying ahead of all of the developments when it comes to COVID, not only with health insurance, but also with how we treat employees and human resource issues. So we've seen a lot of us spend a lot of time on webinars each and every day, whether it be an insurance carrier, whether it be a human resource provider. We're trying to soak in as much information in an evolving timeline here and expand our knowledge and be a resource for all the folks out there that truly need it at this time. But over and above just health insurance, I wanted to touch on just another thing that maybe is getting a little bit swept under the rug. We haven't heard too much about it, but that's the mental toll that has taken place on a lot of folks as it comes to this social isolation, right? I'm not embarrassed to say that I'm on the verge of going stir crazy. I've got 3 kids, and managing them all day and managing a very busy schedule while being home is quite a task. It's not something that I'm used to. I've never done it before. But there are folks out there that are way worse off than me, folks that have lost their job, that don't have income coming in, that are socially isolated and feeling that toll that brings. I wanted to highlight what I consider is a low cost and high value proposition, and that's the idea of an employee assistance program. No matter the size of your organization or if you're just a sole proprietor on insurance, you can add on what's called an EAP program, an employee assistance program, for very low amounts each month, in the range of a couple bucks, really. And what this does is it gives you an outlet for mental issues, financial issues, health issues, just someone to talk to. It's a 24-hour phone hotline for consultation. There's usually, and I'm speaking in generalizations here, but all carriers have this. There's libraries of information online to help with questions regarding COVID, including webinars and emotional support, people to talk to. We have links to updated policies and articles, and it goes beyond just COVID. Also, it also talks to how do we deal with our children right now, or if we have elders that we're caring for under these particular situations. It gives us tips and pointers on how we can get through all of this. And then it also expands to providing financial and legal information should you need it. So that would be something that I wanted to just tout just a little bit for you folks, is if you're finding yourself in a position where you or someone you know is having to overcome some mental hurdles with what is going on in the current times, an employee assistance program is a good way to at least dip your toes into the water of speaking with somebody, and you'd be surprised just how much benefit folks will find from just having an outlet at this particular time. With that being said, our jobs right now are to continue to monitor what is an evolving situation. There's news every day. It seems like we wake up and hope for the best. I think from this last week, I think the general feeling is that we are starting to see results. We're starting to, and if the stock market is any indication, there is some positivity, there is some light at the end of this tunnel as we continue to hunker down, keep our responsibilities in front of us, obey the social distancing requirements that are within each of our states and our societies. And at the end of all of this, we'll all come out for it better. we are very positive about that, and we're hoping that we're going to be able to see everybody out on the golf course very soon.
Well, Mike, thank you. And is it safe to say that the EAPs are available pretty much from any coverage someone might have?
Yeah, you should. At this particular point, we're still in what is called that special enrollment period. Carriers, they really want to get folks covered as much as they possibly can. So whether you have an Aetna or a Anthem Blue Cross or a Kaiser, you should really contact them and ask about an employee assistance program that you can tack onto your current policy. Like I said, the cost is so minimal, but the benefits are so high. It'd be something that I'd highly encourage. And with this special enrollment period, you should be able to add it right now with no issues.
Thank you so much, Mike. And we want to be sure that we get to our next speaker, Steve Tellis. And so we'll be gathering up the questions from the chat boxes and getting back to everyone. So Mike, thank you. And again, hope you're able to join us for the remaining time here this morning. Next up, we have Steve Tellis. Steve is an attorney, and you got a little bit of a preview when I shared my screen recently with the firm of AFRCT. In Pasadena and Seattle, graduate magna cum laude from USC, and also receiving his JD from Stanford. So Steve, thank you for being with us this morning to walk us through some of the myriad of issues with unemployment, and particularly relative to independent contractors, sole proprietor, but again, to everyone that's with us this morning.
Good morning, everyone. As an initial matter, the way that unemployment typically works is an employee is laid off or is terminated for a reason that's not a major policy violation, and then they receive unemployment for up to 26 weeks, depending on how long they worked. With the CARES Act, which was passed specifically for COVID-19, unemployment is extended up to 39 weeks, and employees receive an additional $600 per week. Now, that only goes to July 31st. In addition, in California, the typical maximum weekly amount is $450. So now you get to get $600 on top of that if you're an employee who is laid off. The issue is that the CARES Act also talks about business owners, self-employed persons, independent contractors, and others with limited work history now being eligible for unemployment insurance. However, there has not been much guidance on exactly how to qualify for that, which is causing confusion. At the moment, the California EDD website, Employment Development Department, which handles unemployment, they talk about how there are no set standards, they're being developed, and to please continue to look at their page to see when unemployment benefits might be available to independent contractors and self-employed, and what the parameters will be for eligibility. At the moment, to be eligible, the only guidance we really have from the federal government is that if you either basically have the virus yourself or been harmed by it, or you're caring for someone who has the virus, or your work has been directly impacted because you have to be at home with kids you wouldn't normally have to be, or certain other parameters basically tied directly to the virus, you can qualify for unemployment. That's what we have right now. There's also vague language that the government uses, which says if you work as an independent contractor or you're a small business, you may be able to qualify because the health emergency has severely limited your ability to continue performing your customary work activities. Now, what does that mean? We don't know. So we're waiting for more guidance, both from possibly the federal government or maybe the state of California, in order to determine when small businesses and independent contractors first can apply, and second, how they would be eligible. Do you just state, for example, that your work has been reduced? Also, do you have to look for another job like with other people? Because self-employed people typically want to maintain their business. And what I'm referring to here is strictly unemployment insurance. There's also relief for small businesses, independent contractors per the EIDL and PPP provisions of the CARES Act. And I'm not sure how those will overlap. In other words, if you're getting unemployment, can you still qualify to apply for the EIDL grant of $10,000? Or can you still apply for the Paycheck Protection Program, which is designed to replace roughly 8 weeks of payroll costs? It's unclear at the moment. So we're kind of working in a vacuum in regard to unemployment insurance. So I would say that for the moment, what we do know is small businesses and independent contractors can apply for the PPP loan and also for the EIDL grant, and they can go about doing that, and hopefully that will also allow the person to apply for unemployment, or one will offset such that the person would still receive a decent amount of benefits, or roughly the same depending on what they had applied for. We just don't know how it's going to pan out, though, unfortunately. And that's all I have to say at the moment without further guidance.
Thank you, Steve. Thank you so much. I know it's a complicated issue, particularly trying to work out the details while the system is being absolutely inundated with applications. So, Steve, a couple of things. Are furloughed employees eligible to use their PTO perhaps? And even in part two, are they also eligible for the additional $600 a week from the federal government?
My understanding is yes, furloughed employees would be people who are receiving either no wages or less wages, and so yes, they can apply for unemployment. And I don't see any barrier to that.
Okay, Steve, thank you. So as you talk about working out the details and such, and this might just be a guess, but how do you see the guidelines coming down? What is the EDD working in concert with the state, in concert with the feds, to determine when the details roll out? Do you have a timeline for that?
We don't have a timeline. I hope it will be sometime within this month or at the latest next month, because the extra $600 payments end July 31st unless the government extends them. So as soon as possible would be the best solution. I want to get back quick to furloughed employees, because my understanding is you could qualify, but the EDD uses weird language for a lot of these types of situations, such as you may qualify. Now, I don't see any barrier because your work is reduced, but are they then going to have to look for another job is the question. That I don't know.
So Steve, in that sense, what's our best defense? Just to keep checking. Obviously, we're putting out for the state of California, between our two sections, as much information as we have. And also, is it just to keep checking the EDD site?
Yes, it's to keep checking the EDD site for UI, and if a person qualifies, perhaps also applying for the EIDL grant and the PPP loan.
Okay, Steve, thank you so much on another complicated issue. And as Steve references the EIDL and the PPP, please be aware that the links are available on our site, ncpgalinks.com, and on the Southern California scpga.com as well. So we certainly, one of our stalwarts and great leaders through this whole thing has been Craig Kessler, Director of Government Affairs for the Southern California Golf Association. And it just wouldn't be right to have a session without Craig. So Craig, the most recent guidance, please, on what's happening in the great state of California and the game around the country.
Thank you, Lynn. Thank you, Tom, for inviting me. Great group of speakers you got today, and they were extraordinarily informative, not just for the PGA pros on the call, but for yours truly as well. Congratulations to you. I just answered a question and answered it to all because a lot of issues and problems have come up, particularly with the Paycheck Protection Program, in terms of accessing it. Banks often don't understand the rules. You just heard from Steve tell us that nobody understands the rules and there isn't clarification. But I want everyone to know that yesterday, the Democrats in Washington stopped the addition of $250 billion more to the existing PPP. And one of the specific things that they raised in stopping it to try to get clarification was precisely one of the questions that came up in the box about what do you do if you don't have a bank account? What do you do if you don't have, if you're not a previous borrower? All those kinds of things. So there are a number of things that have become apparent as problems. All of those problems tend to affect those who I'll just, for want of a better phrase, are in the bottom 50%, bottom 60% of the income swath in the United States. Those who don't have access to sophisticated lawyers and accountants and persons they can pay to put together 70 and 80 page applications with corresponding material. So that's a piece of good news for a lot of persons on this call. Piece of bad news, and I'm not surprised by it, but others may have been. There's been some sense, we all know that the PPP did not include any C corporations other than C3s, traditional non-charitable, charitable nonprofits, and C19s, which are very specifically veterans groups. So it doesn't include, for example, the Southern California Golf Association or the PGA sections north or south. And it didn't include any of the C7s, which are all the private country clubs in the United States. There was some sense that might be amended back into the act. That has now been totally taken off the table. I was informed of that last night, which is disappointing. I hope that I've been making some queries as to whether there are some alternative strategies. I've been saying that from the beginning because I thought it was highly unlikely that, having been in the original act and then stripped out intentionally in order to get the votes necessary to pass it, that it would be put back in. So I just wanted to bring that fact to everyone's attention. So there's a bit of a good news, bad news thing with the national legislation. And I think, as you heard from public health expert from Solano County, yes, there's much about. He came up with a great line, and it's a line that I used, close to 1,000 times when trying to explain some of the problems with Assembly Bill 5 and the entire independent contractor issue. Governments make rules that have to apply generally, and reality is so much more complicated. And particularly in that case, we're talking about the reality of the 5th largest economy in the world. In the case of a brand new virus that we don't even understand yet, that reality is of a slightly different nature, but it perhaps is even more complicated. So I just want to share with everyone before I yield back the floor, because we're coming up short on time, is that I think statewide, all of the organizations, including the 2 sections, the amateur sections and the owners associations and everything, have coalesced around this strategy that we're in, and I've used this phasing methodology. We're in phase 1. Right now, it's, as the doctor explained, everything is geared towards ensuring that at all costs, with rules that are inequitable, that are overly generic, and are overly restricted, and not the least bit nuanced, making sure that the health system is not so overwhelmed that literally that persons don't end up dying who otherwise wouldn't had we kept the pandemic curve a little bit flatter. It didn't spike beyond our capacity to take care of. We will at some point get beyond that. As you heard, it's not going to be an all clear. There'll be a point where we can begin reintroducing certain things. And I think the take of the golf organizations has been golf is appropriate when that time comes. And when that time comes will be determined not by us and really not by the governor, but by public health officials, as you heard on this particular call. They're the subject matter experts. And when that comes, golf is peculiarly amenable to a very early reintroduction, along with many other things that are similarly situated. I think there are a lot of other activities that are going to come much, much later. And so I know that everyone is uneasy, impatient. We're in uncharted waters. I bet you've heard that phrase a few times in the last few weeks. But that's sort of the statewide strategy moving forward. And we think it's an effective one. And we think that there are examples in this state where some of our golf facilities have become a little rambunctious and thought to put considerably more nuance and specificity into their particular ask, not recognizing that they had in common with 30 or 40 other asks, and losing sight sometimes of what the overriding concern has been right now in this phase 1 of dealing with the pandemic. And it hasn't worked well. It's actually boomeranged and reflected very badly on the golf industry. So, and reflected perhaps badly on our capacity to be among the early reintroductions when we get out of phase 1 of dealing with the COVID-19 curve. So that I packed in a lot of words in a short period of time because we're short on time. And I hope I shed a little bit of perspective and light on the situation and didn't confuse things more. But again, thanks, Len. Thanks, Tom, for inviting me. Interesting times we live in. And as I've been saying in recent weeks, for me personally, I can't wait till we're back playing a lot more golf for more reasons than just playing golf. I'll be a lot less busy. I've never been so busy while we're not playing golf, while everyone else is trying to figure out, going stir crazy and figuring out what to do.
Craig, thank you so much. And, you know, we've said it a number of times because we should. Craig has been absolutely tireless in meeting our requests to come on at any time, not only on these chats, but on section chats and many others. So Craig, thank you for keeping us posted. Clearly in any one of these areas, we have so much to do and so much to learn, but we have a much greater understanding of why we're doing some of the things that we are doing currently and how this will ultimately roll out. So Dr. Mathias, thank you for being with us today. Mike Bryan of Dudum Financial. Mike, thank you so much. Steve Tellis of AFRCT for joining us, and of course Craig. And I'd like to turn it over to our partner in this great association we have in the state of California, the executive director for the Southern California section, Tom Addis.
Yeah, thanks, Len, and thanks to the panelists once again, and to Craig. Very, very good. At this time, if our president Tony Latendre is still available, we'd like a short message from Tony, and then we'll wrap it up.
I am, and thanks, Tom, and thanks everybody for the time this morning. And I think the short message I'd like to leave you with, and maybe kind of leave it on a positive note at the end if I can. But I think at the end of the day, as we learn all this stuff that's coming out, I think the biggest thing we can all do is just be patient. Wait, there's as much information as we're getting, keep in tune on it. As far as the news goes and things like that, I find myself watching a heck of a lot more news than I ever have, and trying to weed out what's fact and what's fiction or what's hearsay or whatnot. But just be patient as it's weeded through, and rest assured that in Southern Cal and in Northern Cal, we've got some great leaders that in our section offices that are trying to find as much information for us as we can, and with our partners through our allied associations, as by evidence by everybody we got on this call. There's a lot of people that are trying to help get you information, so just be patient with that, and we'll all do our best. The other thing I'd like to remind everybody is that I'm available. You can call me at the club, or you can call my cell phone, which I think my cell phone's up on our website. If it's not, we'll make sure that is up there, but I can be reached via email or called at the club if anybody wants to just chat, talk some things through, get some ideas, hear what we're doing here at the club to try to get by, and those sort of things. So I encourage that if anybody wants to do that. And the last thing that I have, I'm going to leave us with a positive note, just as a reminder that despite everything that's going on, today is our great association's 104th birthday. So happy birthday to the PGA of America, and congratulations to all of us for being associated with this great association. So Tom, thanks, appreciate the time, and Len, and I'll turn it back over to you.
Thank you so much, Tony, and happy birthday to the PGA of America. And again, ladies and gentlemen, we can't thank you enough for your support and guidance as we constantly come across really more questions than we have answers. And as you heard from the experts today, there's still much to do, and working together and staying in touch has proven to be such a great tool and one of our weapons during this pandemic. So please be sure to stay in touch with the resources that are available on our websites, our contact information, Tom Addis, T Addis at pgahq.com, myself, L Dumas at pgahq.com. We will get to the questions that we have not answered and get those to the appropriate individuals and get those answers posted as well. We'll stay on our schedule for our chats on Mondays and Fridays at 10 a.m. And again, your feedback guides us to the topics that we need to address. And certainly, we want to stay as close as we can moving forward in these complex issues. So, Tom, a final thought, perhaps?
Yeah, Len, thanks. One more thing to be aware of, that these chats are worth MSR credits. We will be posting the credits as quickly as we can. And so please be patient in that regard with the numbers of programs that we're doing through the week to keep everyone informed and engaged. We're having great attendance today. We had around 230, which is fabulous. So have some patience with the MSR. And as Len said, we're looking forward to another excellent chat on Monday at 10 a.m. and then the following Friday, next Friday. So be safe and be healthy. And thanks for being with us.
Okay, and enjoy the weekend, everyone. And of course, those of you that do observe Easter, happy Easter, and we're a day closer to rolling out. So good health and safety to all, and we'll see you in next week. Please stay in touch. Thank you.
Day closer.